pay attention to a lot of stuff, and it's partly my wife's fault. She will start a conversation in an empty room, and next I know, there's five people talking to her, and she'll come back and say, "Well, that lady's from Germany, and that person's from that." She engages with everybody. So I had to pick up something in 25 years of being married with her. So I pay attention to things, and I'm just as likely to make a comment at this young lady here. I saw you wore your work shoes today. You're the one with the heels, right? Yeah, I saw you walking through, and I said, "That's a therapist there. She's really going." And little things like that, I think engages you with other people more and stuff. So I enjoy doing that. I'm sorry if I embarrassed you or not. But I got put in a lot of embarrassing positions. The previous speaker, Tammy, and stuff like that. I got a couple clues as to what people can do, at least how I got through this. I started my anesthesiology residency in Charleston, and if you came out the OR, if this is the OR door, that wall's the ICU. 2 weeks after I started my residency, my older sister, by just a couple of years, started working as an ICU nurse there. Had been an ICU nurse previously in other places, but she moved down there. And I can tell you, for the next 3 years, everything that anesthesia did wrong in the ICU was my fault. But I figured this out pretty quickly. I'd get called, I'd get paged in the middle of the day. So next time you're free, come over to the ICU and straighten this out. And come over and like, why am I undoing the lines from the cardiac room? I'm doing urology today. What's going on? Well, I can tell you, if you interact with people and especially if you go in between departments and stuff, yeah, I've gotten that crummy report from the ER or whatever and stuff like that. But other times I've gone down to the ER and I talked to the therapist and I said, "Well, you were just up in the ICU last week. You know what they need to know. Talk to each other, teach each other." Now, I've got an advantage, as faculty, and then later, I've got up to full professor somehow, based on a lot of papers, a number of which were written with the respiratory therapists that I worked with and stuff. So I've got an advantage. I can tell people a little bit what to do and stuff. It's harder to educate people when you're equals or they think you're lessers. But you have to take that opportunity to do that. And then the outside of the hospital interactions. If you never talk to somebody from the ER in the hospital, you're never going to talk to them outside the hospital. I loved being in places where we had intramural sports and stuff. Our OR team could beat almost anybody if we weren't all on call every night, and you couldn't get a team together. That's how I got into medical research. My sister, when she was in nursing school and I was in college, her and her nursing school classmates dated all the surgical residents who had basketball and softball teams, and they were always short of players. So I got drafted to come across town and play softball and basketball with them, and then eventually got offered a job in research because it was either work in research doing liver transplants on pigs, or I had a job offer to teach 1 through 5th grade Phi Ed and social studies in a little Catholic grade school 40 miles outside of Milwaukee for half a day, $5,500 a year, and no benefits. Now, this is a while ago, believe me, before a lot of you were born. But I tell you, that was not that glamorous sounding. So that's how I ended up in research. And speaking of research, this is one of the things that I'm interested in. And it's an interesting concept. And it's something I want you to think about when you go back, because maybe you can do something about this. If I can get this to work here. Yeah, I have no conflicts of interest. I don't get paid money by anybody whatsoever. No drug companies. I've tried, but So a number of years ago, I was at a meeting. It was actually a NAMDARC meeting. Okay, just by hands. Anybody know what NAMDARC stands for? That's what I have. National Association of Medical Directors of Respiratory Care, which is now a defunct association. He actually got bought out by Chest, but that's something different we can talk about later if you're interested. But 200 or 300 people would get together out on the West Coast every March, and I got interested because they were meeting in the Sonoma Valley every other year. So I said I could go out to that meeting. And they had some interesting speakers, and then they would have interesting discussions. We spend more times at the lunch table and the dinner tables talking about things and learning stuff from each other than we did listening to the talks and stuff. And one of the guys came up and said, I saw this paper and I've looked around and stuff, and I said, what do you know about this? What is going on and stuff? And I tell you, it's in anesthesia too. So these were a couple studies people did, and they looked at hip fractures, a lot of patients, almost 9,000, and 20% had postoperative complications. Well, your hip fracture patient is not your healthiest patient to begin with. And, I tell you, when I was on call for anesthesia and they come, the ortho guys would come by and say, we got a couple of hip fractures. You're just like, there goes the night. Because, ortho's not getting them ready for the OR. They just bone broke, we fix, type stuff. So when they had complications, there was a greater number of complications from pulmonary problems than there was from cardiac. Now, in a couple of months, I'm going to go to Myrtle Beach speaking in an anesthesia review course. And one of the particular talks they asked me to give was, how do you pre-op somebody for non-cardiac surgery, a cardiac patient for non-cardiac surgery? And I'm sitting there going like, one of the things I need to throw out in the middle of that is that there are more non-cardiac complications than there are cardiac complications. And maybe we've been looking at the wrong thing. Now, that's from my side, being an anesthesiologist, and we're always, somebody's heart stops. Yes, that's not good. I understand that. You're the respiratory field. You get stuck with these patients afterwards, but maybe we can do something about it beforehand if we know what's going on. There was another study of older patients, although 70 is not that old anymore, I'm sorry to say. Pulmonary and renal problems showed what was going to happen to the patient afterwards, not cardiac patients. And this is a big case. You get somebody get esophagectomy, and I've done a bunch of those. I don't like any of them. Surgeon, is mucking around in the middle of this guy's chest for a long time. There's a lot of things in there they ought not to touch, and a lot of them bleed, and those people are not that healthy. You're getting your esophagus taken out because you got bad cancer, and you haven't been eating for months and everything. Bad patients. But even that, the biggest thing that said whether or not they were going to do well afterwards was whether or not they got a pneumonia. And I'm sitting there talking to the surgeons, and well, we want to make sure he doesn't bleed too much, and we got to take care of that. And said, you got to make sure somebody's taking care of his respiratory problems post-op. That's what's going to kill him. So this group, as I said, this NAMDARC, we're talking about that, and among those people, and luckily there were some vendors, kind of like you have here, and we're more than willing to take advantage of vendors whatsoever. They got some free grants. There were some very politically savvy people in here who have known companies for quite a while and said, we've got an idea we want to get started on, but we need some seed money. But we're going to do what we're going to do. You can't tell us what to do with money. Well, you don't get a lot of money that way. You tell them you're not going to espouse their instruments and everything. But they gave us some money, so we got together, and these are some of the groups that were part of that. Of course, the AARC sent representatives. The Canadian Society sent representatives. You talk to those guys every year. They were down in the Napa Valley, Sonoma Valley, out of Canada in March. Oh, they were ready to go. They loved that. NBRC sent people, ASA, CHEST, American College of Physicians, AANA, SCCM. All these groups sent people to that and said, is there anything to this? Can we do anything about it? First thing they did is said, talking about things and looking for, we think you have to have a definition of it. Is there a problem? What's the definition? Whoops, excuse me, hit the wrong button as usual. So we think there's a state that at some point in time, a patient is getting close to impending respiratory failure. If we do something about that, if we recognize it, can we stave it off, whether it's through enhanced monitoring, other therapies? I'll show you some of the work, a lot of work that people did trying just to pick these people out pre-op and everything and say, what do we need to do for these patients to avoid them having problems? And you want to stop that decompensation. You're like, okay, yeah, so there's problems. How bad is it? Well, one of the first things we did, and there's Medicare data out there. Believe it or not, there's a lot of people on Medicare. And the government collects a lot of that data, but it just sits there. If you call the government up and said, tell me how many people had, post-op pneumonia, they just look at it like, we don't know. Don't even know what that code number is. But you can find companies who will dig through this, and you can just pick up, give me a 4-month total. Across the country, how many people had post-op pneumonias? Or how many people got re-intubated after being admitted to the hospital and stuff. So you can get an idea of what's going on. You don't get all the details, but you get some idea of it. So this is one of the first parts they did. They looked at, so here they had almost 30,000 patients, medical and surgical. They all came about the same time. If you were a medical patient who developed respiratory failure after hospital admission, you were not admitted in respiratory failure, but you went into failure after admission. Some point in time when you and I and whatever could have interacted with them if we knew where they were and what was going on. And we argued about that. He said, well, how good is this? When we say it's after admission, try to find a hospital will let a patient come in, be admitted who's in respiratory failure, and that diagnosis is not on their admission sheet. That hospital gets paid by those kind of diagnoses. So this is not bad data. But if you were a medical patient who developed respiratory failure after admission, in-hospital mortality, 33%. Now, there weren't a ton of these patients who did that, but of the ones who went into respiratory failure after admission, 33% died. Maybe you could have avoided that. Surgical patients, about 1 in 4. And as much as some people will tell you there is no difference, or there is a lot of difference between surgery and medicine, I'm an anesthesiologist. I interact with a lot of surgery patients, although once I'm in the ICU, and I do both, when I'm in the ICU, I interact with non-surgical patients. It helps a little bit if you've got a surgical patient who had a problem, and at least we fixed part of that. So I think that's a lot of the difference in here. And the other thing is that if you're admitted as a medical patient, it's rarely an elective admission. You get that. For surgery, we can do a lot of emergency admissions and stuff. But we do a lot of elective admissions with surgery. And so that patient is supposed to be in optimal shape. So I think that has a lot to do with the difference here, but not all of it. If you got them through the original part and everything, even the 30 days post-discharge, medical patients were still almost twice as much likely to have mortality. The next thing that occurred besides the respiratory failure is, did they go into acute kidney failure? And again, that's something we don't think too often, but I was good to hear there was some of the questions in the sputum bowl that yesterday talking about electrolytes and other things and stuff like that. So that you're being taught. That's what you're supposed to do. I'm on the NBRC. I help put together exams. We rewrite some questions, but we have questions on there. I'm not supposed to say exactly on what, but there are questions on there that have something to do with renal failure and problems and how that affects things. The other thing, you're trying to pick these people out. Majority of patients in both groups, the ones who had problems in respiratory failure after admissions, they had been in the hospital within the last year. They're not the healthiest patients, at least in the Medicare data. We should be able to pick these people up. There should be a red flag on their chart when they come in and get admitted the next time and say, hey, you need to pay attention to me, because I don't want to be a mortality statistic. And the other interesting thing is that more medical patients came from a SNF, skilled nursing facility. Again, that's kind of a flag. You got to pay attention to that kind of stuff. But here we find it out from Medicare data. I'm not sure. It was rare that if I was doing, unless a patient got admitted, was going through the OR and going to the ICU, I wouldn't have known where they came from if it was a sniff beforehand or not. The surgeon just posts the case, and we're trying to make sure they're as ready as possible. And where were you staying or being cared for the last couple of weeks doesn't always come up. And I've never got a chart from one of those places that told me, how they were doing recently and everything. And don't ask the surgeon. He said, I just got a call and said this guy needs another G-tube put in. Not enough information to help. All right. We're moving. They kept looking at this information and doing some more, and they tried to call me. So maybe we could call it hospital-acquired respiratory compromise. Again, we have a lot of patients diagnosed at admission, 18,000. One's diagnosed after admission, and the in-hospital mortality was 5% higher if it was diagnosed after admission. 1 out of 20 patients. If it's in your unit or it's on your floor that week or a couple times that month, you start paying attention to that. But it doesn't rise to the occasion because you're not looking at all the, whoops, sorry about that. Jeez, I have trouble with these things. You're not looking at all these patients. You're looking at, a couple of them. And you had one in January and you had one in October. You don't put that together. You're not thinking that way. You're human. Unless that patient was related to the other one, you don't realize how similar they may or may not been. And again, the hospital mortality was worse, 3 or 4% more. Now, those are the kind of numbers that in large groups gets people attention. At your institution, maybe not so much, because you didn't have 19,000 patients and stuff. Maybe you only had a couple hundred. Does it make a difference? So you have to look at it, go from the big picture down to the small picture, and you got to see what's going on in your own picture. The big thing they came out, and this was published, first it was in an abstract at ATS, and later they published in Respiratory Care. Again, respiratory failure at the time of admission was, those patients did better. Because as soon as they got admitted and somebody said respiratory failure, you guys were called. You were taking care of them right away. Maybe you couldn't do everything for them. They're still really sick, but you had a chance. If you got called 3 or 4 days later, and it was at the time when they came in with chronic heart failure, hypertension, AFib, renal failure, pneumonia, and septicemia, add late respiratory failure on top of that, and you're looking at them in the ICU just going like, get the family together. We got to talk to them. This is not going to go well. And you know that even if you get them through the ICU, they're not going home. They're not going home to a normal life afterwards. So it's tough to take care of those patients. Don't try to read this. You can look it up in Respiratory Care from about 4 or 5 years ago and stuff. When we looked at the Medicare data and we asked specifically, said, okay, we need a little more, dig deeper on some of the patients. There was a number of different ways the patients failed after admission. Some of these talk about neuromuscular disease. Some of these talk about other things that happened to them. And if you want a copy of these slides, I have no problem with the FSRC sending them out. They'll give you my email address if you want, or I'll give it to you if you have a question after you want more of this data. I'll give it to you. That's okay. So I can't read it from here, so I know you can't, so don't worry about it. But it isn't just one problem. That'd be easy. If everybody who came in who got diagnosed with respiratory failure after admission had bad asthma, well, hell, we can take care of that. Just hit me at the ER, everybody's got asthma, and they're not going to go into respiratory failure afterwards. But there are a lot of different conditions that all lead to the same outcome. But what we did look at and what we got a consensus from, and the data did tell us, that respiratory compromise, the estimated, looking at the data and looking at a number of individual patients, that up to 64% of the mortality from that could be prevented if we'd have done something beforehand, if we did something different. And that, you know, those, it may be 64% overall. It may be 80% in your hospital. It may be 10% in your hospital because of the patients you have and the difficulty of trying to find those patients and sort them out. It's the number one antecedent for a code blue. Hearts will stop on their own occasionally, but they stop a lot more often, give problems when the patient's hypoxic. Add hypercarbia on top of that and everything, you get the code blue. So you'll see them, but it'd be nice if you'd have seen them beforehand. It's the number one trigger to rapid response calls. Does anybody have come from an institution that doesn't have a respiratory therapist on your rapid response group? Good. I mean, why would you have why would you have that team if you didn't have a therapist on it? It's the number one cause of post-admission ICUs. You got a patient who's been in the hospital for a couple of days and ends up in the ICU afterwards, it's because of respiratory compromise. Their respiratory system is doing worse than it was when they came in, recognizably worse. You got to make these numbers up. It's some statistician, economist looked at this, blah, 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 blah. Oh, yeah, $37 billion 3 years ago. Now, if we had one big hospital system across the country, and I came up to the guy who was running that hospital system and said, I might be able to save you up to $37 billion, I'd get their attention, and we'd do something about it. But in your hospital, you may have let's say you're a big hospital. I was at Bay Pines, a couple hundred beds and stuff like that. We had between 100 and 110, maybe 120 in a bad year, out of OR intubations in a year, of which 95% were done by respiratory therapists, intubated after hours. Even during the day, with anesthesia fully staffed, we didn't go out to the floor and intubate anybody. We helped train and we kept credentialing the respiratory therapists. They had come in and out of the OR and everything, and they intubated almost everybody. We also had the pulmonologists come through. We also had the ER physicians came through. And we also told the respiratory therapist, run faster because you got to get there before that pulmonologist does. Nobody works at the Bay Pines VA, right? Because we brought the pulmonologist in. The head of pulmonary medicine a number of years ago was the only board certified in critical care, been doing this for years. He knocked out the only non-loose tooth I ever saw in my career. He was just levering. Stop that, snap. And the only one that sticks out because it's the only one I ever saw. And two, because I was proctoring him, I got called before the M&M board at the VA, not him. I didn't pass him. I said, you're not allowed to intubate. You got to come back and do training again. I had to sign off and anybody could intubate. You don't get that power, but I tell you, when you got that power, you got to do something with it. So now we can go through some studies that have been done. And these are, a lot of them multi-institutional. These are outside of any of your ability to do, no question. And I'm not telling you to go home and try to find 50 other hospitals to sign up with and do things, but trying to tell you, maybe you can do something smaller in your own hospital and see what you're doing and stuff. This is I don't know where they came up with this. Assess respiratory risk in surgical patients in Catalonia. So it's Spain. They looked at 2,500 patients or so, postoperative pulmonary complications, which was either an infection, failure, bronchospasm, atelectasis, pleural effusion, pneumothorax, aspiration pneumonitis. When you read papers about this, and I hope you have time to read some papers. I know you're busy at work, but read as much as you can. A lot of it about what you're doing every day, but then every once in a while stray outside of that. Look at something else so you know what's going on. But you got to look at how they define things. Because my respiratory failure is maybe not your respiratory failure. So what I do about it may not work with you, and vice versa. So you have to go through those things. They had 123 patients, but only 5%. That's actually pretty good. But 252 events. But the mortality in patients who had one of these problems after surgery was 20%. Less than 1% if you had no pulmonary complications. If I'm a surgeon and I've got some of these people, I'm asking what's going on in the rest of the hospital. And what you ought to be asking about is, who do I need to see to make sure this patient is taken care of right? Because he's the one seeing them first. They came up with 7 independent risk factors. And there are a number of the studies I'll go through have different risk factors, but they look a lot alike. Low sat pre-op. Of the pre-op patients I see are ones who have been sent to me through a pre-op clinic who has been staffed by either a CRNA, an ARNP, a internal medicine specialist or whatever. I can't remember. I mean, I don't know. I guess they don't have a pulse oximeter in the office. I mean, you got to sit and talk to the patient for 5 or 10 or 15 minutes, put the thing on their finger and tell me what it says. And if it's reading in the low 80s, maybe you ought to call somebody before we operate on that patient. Because otherwise, I'll see him right outside the OR. We take him in the OR, and as we're putting all the monitors on him, that's when we put on the pulse ox. And it's a race to see if the pulse ox got on before somebody put the oxygen mask on. And if you're looking at somebody who's got the oxygen mask on and he's still talking to you and the SATs are in the 80s, I mean, I've told surgeons we're done. They're not happy when you tell them you can't operate. And neither is even the VA. That's a $10,000 setup that we've just brought the patient in the room. So you got to take the whole room down. And you're just sitting there going, telling the patient, I'm sorry, I'll apologize to you. Yes, and tell the surgeon, you can't do it today. If somebody would have looked at it beforehand, maybe we would have avoided that. Little things. If they've had a respiratory infection during the previous month, you know how patients are. You ask them, how you been doing lately? It's, oh, fine. And then their spouse will say, well, remember you were in the hospital 3 weeks ago. Different hospital system, didn't show up on these records and everything. And you know, well, I had pneumonia, but I saw the doctor afterwards. He said my pneumonia's gone, so what's the big deal? It took about a year into COVID before the ASA and other anesthesia groups came out and said, if you had a significant COVID infection, which meant you knew you had COVID, basically, at that point in time, and you felt better 6 weeks, 8 weeks, 10 weeks later, it's still not a good time to go have anesthesia and surgery. We've gone from 12 weeks out that you should do it. They've cut it back to like 8. But again, now we're able to quantitate a little bit more. How sick were you? How bad were you? And we can get your records and look at it and say, yeah, you're not coming in for elective surgery. Well, I feel fine. Yeah, I'm great. No, you can't do it. If you were anemic, if you were old, where are they operating on? And if you look at this stuff, you can measure this, you know their H&H. Their age, we can't do anything about it, but it's there. What kind of surgery are you going to do? It's planned surgery. We know where we're operating. And regardless of what the surgeon says that he knows he can do this in less than an hour, ask me, I can tell you he's never done one less than 3 hours in his life, so it's going to be a long surgery, or if it's an emergency surgery. Sorry, I keep bouncing that again. So a lot of this you can tell beforehand. Those patients are there to be seen and cared for. Whether or not we do something immediately before surgery and, get them going in the right direction, or whether or not we put off surgery a little bit, look at why this is something we can do about it. We take time off afterwards. If you're taking care of patients who look a lot like this, you're going to have some post-op respiratory failure in patients who didn't look that bad when they came in. And we shouldn't be doing that. They came out their conclusions. He said, of course, it's a major contributor to the overall risk. And this is when you get back to the hospital. They're going to stay in the hospital longer, and more of them are going to die. That's kind of the baseline. Sometimes you have to tell the patient, say, look, I'm trying to look out for you. We're trying to be nice to you and take care of things. This is when they went back and looked at some of these things as to what it was. If your post-op SAT was less than, our O2, PaO2 was less than 60, or SAT less than 90 post-op, you're in bad shape. Put oxygen on them and it's still real low. If I didn't know there was something wrong with you, now you're in the recovery room, hey, somebody needs to see this patient. Somebody needs to be aware of what's happening. Well, I drove surgeons crazy. Because even intraoperatively, immediate post-op, give them a call and said, your gallbladder patient? Yeah, he needs to go to the ICU. What? I never put my gallbladder patients in the ICU. Well, this one you are. He's not doing well. We need to do something more for him. And a lot of those times, I was able to call a surgeon because one of your fellow comrades walking through the recovery room or seeing a patient called me and said, this is not a good patient. They're not in good shape. So they got recognized on it. And this is, again, post-op. They have pulmonary infection. You got to look for that. Think about it. Check those people. We do all this. We think about ventilator-associated pneumonia and everything. Well, this is before this happens. That's that patient just laying in bed and doing nothing. And whether you believe in incentive spirometers or not, I don't care. I think if it's attached to a respiratory therapist who comes in and tells the patient to sit up in bed and take some deep breaths and move around, I think it works. Beyond that, I don't know for sure. But it's you guys doing the work with that. What does the chest radiograph look like? Do we have atelectasis? And I've got some interesting, one of the studies later talks about atelectasis. So all these different things you look for. And if your patient starts having those, we got to do something. And they love to put points and scales together. So all you have to do is memorize this and you can tell what's going on. I'm sorry, if it has more than 3 points, I can't memorize it. And if I have to look it up, now at least I could put it on my phone and I could look it up and stuff. Although you put all this in your screen, it's kind of hard to read. You got to make it simpler than that. But they said if you had more than 45 points, you're high risk for a postoperative pulmonary complication. Well, if your pre-op SAT was less than 90, that gets you halfway there already. How old are you? Between here and here, you're at 40 points, you're past moderate risk already. That's not rocket science. That's just data we have on a bunch of patients. It may not be the same in your hospital, though. Again, you got to look at your own hospital. But that makes things bad. What if they're doing intrathoracic? You got an 80-year-old guy having intrathoracic surgery who, had a low pre-op SAT, and it may be why he needs the intrathoracic surgery. They may be taking a chunk out of his lung that doesn't work very good, so it may get better and stuff. But that's 48, 58, 64 points. You don't want to put them on a ventilator right away, but you don't ignore them. So there are systems to look at things and think about it. This is another one done. It came out in Anesthesiology in 2014. They looked at differences, and that was part of that whole Catalonia study, and they did several iterations of it. And one of the interesting things about it was even in Spain, it's only Spain. Spain's not the smallest country in the world. But it's bigger than your hospital catchment area, I know that. But in that, there was a difference between geographic areas. And you wouldn't think so. And I'm going to digress for this and tell you one little anecdote that has nothing to do with respiratory failure, but tell you how patients are different. So as Tom Berlin mentioned, I was at the Ohio State University, and you said it right. That was good. So back then, drug companies were doing stuff. Anybody know what Zofran is on Dancitron? Yeah, you got that. Well, I was around, hard to believe, but I was around when that first came out. Now, they were giving it to every patient in chemotherapy they could at the time. That's a big market. But somebody in, I think Burroughs Wellcome's had it at that time, came out and said, you know, that's a couple million patients a year in the United States, maybe 10 million. But there's 100 million operations a year. And all those people get anesthesia and they all puke their guts out afterwards. That's the big market. And that makes sense. They don't all puke. Not my patients, of course. But you got to go to the FDA and you have to prove it's worthwhile. So the first study they came out, and we got offered a couple $1,000s per patient. And what we had to do was, if we had a patient, just do regular anesthesia on them, and if they got sick in the recovery room or before they went home, give them ondansetron and see how it worked. And keep track that if it didn't work, what did you have to do to treat them? Not too bad. You had to have a series of lab works and stuff to make sure they were normal patients. But back then, everybody got a lot of lab work, so it wasn't a big deal. We enrolled 19 patients within a couple weeks. And Burroughs Wellcome called us up and said, "You've got 19 patients. That's really good. Only one of your patients got sick. You're out of the study. We're wasting our money on you." I actually got an apology card. There was a professor of engineering who came through, and we discussed doing this study. And he said, "Oh, yeah, I'll help you guys do the research." He sent me an apology card afterwards because he didn't get sick. He said, "I was actually kind of trying. I wanted to try this. I didn't get sick, so you get to do it." And Burroughs was sitting there going, "What are you guys doing? Everybody else's patients are getting sick left and right, and none of yours, so you're out of the study." So there was something different about that area. It took 3 years before Burroughs would talk to us again. We kept saying, "Hey, you got any more studies?" And no, we're not wasting money on you guys. So finally, it got to the point where the real money is not treating nausea and vomiting. The real money is prophylaxis. Because if, let's say, only 10, 15% really get sick, that's only 1 out of 10, 1 out of 6 patients gets it. But for prophylaxis, we're going to give it to everybody. So they enrolled us in that study again. And we weren't being mean, but we were trying to think like what we can do. Now, number of females out here, I'm not sure how many have had laparoscopic gynecologic surgery. That's your realm, not mine. I give you the anesthesia for it, but if you don't get sick after that, you'll never get sick after anesthesia. Between the surgery itself and the gas they put in, your nerves, you being young, healthy, and you're not having this done because you want to. There's something wrong or you're worried about something. A lot of those women get sick. So I was often in OR1 for the day, and that was the laparoscopic gen room. We would do between 5 and 10 cases a day. And we were going to give them, tell them, "You're getting a regular anesthetic. We're not really changing anything to do this. We're trying to see if we can help you avoid getting sick." At the same time, there were some thoughts back then. He said, if you could avoid nitrous, maybe people wouldn't get sick so much. If you never gave them narcotics, maybe they wouldn't get sick so much. So there were some ideas that people were thinking about doing, and we said, we're not going to do any of those because we want the ultimate experience. And unfortunately, thinking about what we wanted a lot of people to almost get sick that we could prevent. At the end of the study, it was double-blinded, so you couldn't look at it. At the end of that study, they had a control group, people who didn't get ondansetron, they just got saline, and then the ondansetron group. Our control patients at Ohio State, the ones who didn't get ondansetron, had the lowest incidence, a lower incidence of nausea and vomiting post-op than all the treated patients for the rest of the study. Our treated patients had an even lower incidence. But I remember talking to one of the Burroughs guys later, and he says, "Thank God you didn't enroll another 50 patients. If you had another 50 patients and only 2 or 3 of them ever got sick in the control group, ondansetron may never have been approved for post-op nausea and vomiting." Geographic areas does something. And I bring that all up and go through that whole thing to let you know is that there are some similarities between some of these groups and the patients you'll have, but you got to look at your own patients. There may be things that you don't even realize you're doing right, or that your surgeon is doing right, or the ER is actually starting before you even get called about a patient, that makes sense and reduces the incidence of post-admission respiratory compromise. And you have to take that into account. So you can't just, unfortunately, grab one of these papers and say, we're going to look just at these patients. It's a good place to start, but you kind of need to do your own study just to make sure. Mass General did a study. Now, you talk to your hospital administrator, most of them will recognize Mass General. A lot of patients. They talked about people getting reintubated within 3 days of surgery. There isn't too many people who won't believe if you're getting reintubated that it isn't tied to respiratory failure. Even the podiatrists know that kind of stuff. Everybody can understand that's not good. 16% of those patients died. Again, a lot of this is elective type surgery and stuff. But if you were not reintubated, almost nobody died. That respiratory failure post-op pushed you over the edge. We couldn't stop it at that point. They looked at things, ASA score, and I'll talk about, again, emergency surgery, the high-risk surgical service, upper abdomen, thoracic, a history of congestive failure, or chronic pulmonary disease. Again, a lot of things you think common sense, but they were looking at different. And I bring this up if you've never heard what the ASA score is, just so you can see it and stuff. One, a healthy person. At the VA hospital, I actually came out one day and I had to stop. We had 2 patients waiting to go into surgery. And I said, you know, I've been here at that point almost 5 years. And in those 5 years, we had a total of 3 ASA1s. Even the young veterans aren't that young. And I had to tell these 2 people sitting there, I said, I don't know how we did it today, but you are 2 of the 3 that I've seen who are ASA1s. At our VA hospital, we started almost everybody at ASA3. So you can't pick in that VA hospital, you couldn't pick as an ASA3 as being a real problem. They were all ASA3s. Your hospital hopefully has I don't want to say a better class of patients, but a healthier group to start with. It gets all the way up to a 4, a 5, or a 6. 5, somebody's not going to, it says not to survive without the surgery. When I was a resident, it was with or without the surgery. That was the one shot that patient had. And you didn't feel real good as a resident going into that room, just like, kind of like, you have to talk to the patient, but like, don't really look at their face, don't develop a rapport, because you know that 50% of those patients aren't coming out of the OR. It's a tough group. I mean, nobody wants to take care of patients like that all day long. So the Mass General study came out, and again, they did points, just like that bigger study. It's a little easier to follow. And he said ASA 3, you get 3 points. You get 3, 3, 2, 2, and 1 for the 5 things they came up with. And if you got, the important thing, 7 to 11 points. So if you're ASA 3, you have chronic pulmonary disease, and let's make it an emergency procedure. That's 7 points right there. You've got a 1 in 20, greater than a 1 in 20 chance of having to be reintubated after surgery, within 3 days after surgery. That patient sticks out. These are pre-op information. You see that, and that patient doesn't get stuck in the back end of some floor where you, as a respiratory therapist, doesn't have time to see them several times a shift. You just can't do it. But if you put it someplace where they're monitored and you get to see them and see them, maybe we can get that number lower. That's the important part. And again, it wasn't, even though they were reintubated and those pre-op values, why did they get reintubated? A lot of pulmonary edema. That surprised me. It seems like a lot, but again, you remember how few of the almost 30,000 patients, they only re-intubated 100 something. So to say that 50% of them, so 50 patients out of 30,000 had pulmonary edema after surgery. Okay, I didn't drown them all in the OR. It wasn't me, maybe. Atelectasis is a big factor. And you know in those things, that atelectasis is, you can see it on the x-ray. There's a big chunk in the lung that's not helping that patient. Something needs to be done. All the way down to airway obstruction, cardiac arrest, pneumothorax, all those different problems. So you can't sit there and say, well, the guy doesn't have pulmonary edema, he's okay. Because, you know, if you're, well, 50% of the people had that, and if he doesn't have it, he's not going to get reintubated. Those 5 things they picked out, age, emergency surgery, or whatever, said they're the ones likely to have problems, but the problems are all different things. Anybody know what NASQIP is? This National Surgical Quality Improvement Program. It was big in the VA. They kept having problems with it, trying to get the computer system work and stuff. I couldn't believe this. They reported, and the guys from our group came out and said, they put that in that respiratory care article, but NASQIP came out and said 1% of all surgical patients required an unplanned postoperative intubation. Now, even though it's a national quality thing, not every hospital in the country puts information in that. And I tell you, if every hospital in the country put information like that and 1% of all surgical patients got re-intubated after surgery, we'd be operating on a lot less patients. That's horrendous. So, yeah, it's the data. It's from a lot of patients. But I think it's from people who report, and they're like proud of the fact that they're having problems. But they actually, you know, a lot of them with the VA hospitals, and they have people in the nursing department and other surgery department whose job is to keep track of all this information. Those people get hired by the VA. We may not have enough respiratory therapists to care for patients. We got several people in the surgery office counting who we should be caring for. Their database came out, identified up to 14 different factors, but the ones with the five highest ones again, there's that older age, COPD, emergency cases. Now, preoperative ventilator status, not too hard to figure out. You came into the OR on a ventilator, you had surgery, you got extubated a couple days later, and you got reintubated a couple days afterwards. Those are pretty easy to keep track of those patients. Again, the first ones that came out was smoking. It's the only one I saw, the only study that looked at, you know, smoking history made a difference. I'm not sure why. It doesn't make any sense. I think it all got told into the chronic obstructive disease and everything like that. But that's a lot of patients, a lot of data, and again, simple to pick out these to look at. Here's another one, a multi-center perioperative research network investigations. And they looked at 1,200 something patients, a lot of different types of surgeries, any pulmonary complications. Again, the mortality goes up, and ICU admission goes up, ICU length of stay goes up. And these aren't people coming out of the OR into the ICU that you can plan for, that you can sit there and say, we need staffing for X number of beds today. Back when you actually had empty beds in the ICU. Not anymore, I know. Type of pulmonary complications they looked at, pneumonia, pneumothorax, atelectasis again is the big one. All these, then they looked at, you know, how did we have to treat these people? What did we get by with? Non-invasive ventilation, nasal cannula. So, but these are things, they admitted them to the ICU. They said, we can't do enough for these patients on the floor. But if we'd have looked at them earlier and started doing things, maybe we would have avoided that kind of stuff. This is another one, European Journal of Anesthesia, over 6,000 patients, a lot of hospitals, a lot of countries and everything. They looked at 13 different independent risk factors. Now, the ones that made a difference, here's the patient characteristics. Things the patient comes in with, you can see right away. They're older, highest ASA score, preoperative anemia again, lower SAT to begin with, and either active cancer or obstructive sleep apnea. Those things are on their admission data. That's as soon as that patient shows up, one of you guys should be getting a call. Come help evaluate this patient. Let's make plans for their hospital course. Let's make plans for their post-op course. Can't do anything about the emergency, urgent surgery, and longer surgery. It just happens. It was interesting, they had some other stuff. Use of an airway other than a supraglottic device. So if you got intubated in the OR, you've got a little bigger chance of getting intubated afterwards. I think that kind of follows through. It has something to do with the fact that you can do a lot of surgeries with just an LMA or so, but they're not big abdominal cases, not big thoracic cases, not 20-hour cases. So you can separate people with that. What kind of anesthetic they had, you have no control over that whatsoever. I'm not sure I believe this. I think when they looked at, when they say intravenous agents along with gas, you can do, they call it balance, but you can do high-dose narcotics, and your patient looks so smooth intra-op. The heart rate doesn't change. If the surgeon doesn't poke a hole in something that bleeds a lot, the blood pressure doesn't change. They just can't breathe afterwards because they're still narcotized. And even though you wake them up enough to get them moving and a little pain sets in and you can extubate them, 2 hours after surgery, put them on the floor, those narcotics just kick in again and they quit breathing. It's tough on them. You got to pay attention to that kind of stuff. Here's another one. They just looked at postoperative pneumonia, go through all the data, a lot of patients. This is the first one, poor functional status. Something else we look at. And it's a carryover with the cardiac status too. You know, and the pre-op center at the VA hospital, their idea of a good functional status is the patient got from the parking lot into the hospital. And it was supposed to be on their own, but you had to ask the patient. He said, how'd you get? Well, the guy picked me up in the golf cart. And he said, well, how far did you walk? I can't walk 50 feet. And I'm on HOMO too, and you know, and nobody noted that stuff. Those people stick out. Again, the low sats. When you're looking at intraoperative colloid and balloon administration, or blood administration, that means they bled a lot. They needed a lot of fluid intraop. You can't control that, but that's when when you're sitting there, you know, walking through the ICU and you hear the anesthesia resident or CRNA or one of anesthesiologists giving a report to the ICU nurse, and they said, well, he had 6 liters of blood loss, so we gave him 12 units of blood. Step back by that patient and say, okay, what do I need to do for this patient? They're not going to do well without your help. Again, the upper abdominal surgery. Up until laparoscopic surgery, the #1 surgical procedure that ended up with post-operative problems, respiratory problems, was what? Gallbladder. You got this big incision underneath your rib side all the way across. You couldn't take a breath for a week and a half without hurting like hell. You could just show the atelectasis on that side. They just couldn't take a deep breath. Another one, and I brought this one up because they call this air test score. Something a little simpler to do and everything. Whether it's pre-op or post-op too, but you can do it. Put the patients on a Veni-Mass FiO2 of 50% for 30 minutes. They said after extubation. You can actually do it pre-op too. You then take the mask off, leave them just breathing air for at least 5 minutes with a pulse ox on them. If their pulse ox stays above 97% for at least 5 minutes after being just on room air, they're in pretty good shape. They don't have a lot of atelectasis. If it falls 96 or below, they have atelectasis. And their data showed that, you know, it's 82% sensitivity and specific, 87. When they did the AirQ test, there was 5 patients who had atelectasis and got a negative air test, but all the patients who were positive, who sat fell, all had CT confirmed atelectasis. So something simple to look at and everything. So what do? You've got your hospital. and you got some kind of data. You're not sure. Well, the question is, does my hospital have a problem? If you're an all outpatient center, why are you in here? Patients aren't going to get post-op respiratory compromise. You'll never know about it. You're in a hospital that does a lot of surgery, has an active ER. If somewhere in your hospital, they keep track of how many people get re-intubated after they've been admitted. Good place to start. And then how many people get admitted to the ICU 1, 2, 3, and 4 days after admission to the hospital? If that number is significant, and significance is to your hospital. If you're filling up your ICU half the time with patients who got admitted 5 days ago and they looked okay and now they don't look so good, that's a problem you need to look at. And again, how serious is it? Look at that data and do it. And again, if you're lucky and your hospital does pretty well and picks them out, great. Don't worry about it. But otherwise, somebody keeps track of that stuff. I had to sign off on every out of the OR intubation at Bay Pines VA. And you said, code, not a problem. Code, not a problem. Code, not a problem. I can't do anything but those. And you're sitting there going like, I kind of remember that name. Last week's surgery. He was on the surgery schedule. Why did that patient have to get re-intubated? Was there something we could do about it? And can you evaluate? Do you have the ability to evaluate that? When you're all working 12-hour shifts because you don't have enough people, no, you're not going to do it. It's not physically possible. Unless you've got a box someplace and you said, put a name in there. Every time something happens, just put the card with the name in there. And maybe in the future we can look at that and do something. Someday when I'm bored. You think COVID is going down? People are saying things aren't so busy and stuff. A couple weeks ago in the United States, less than 500 people were dying a day. And we were celebrating. 2 days ago, 1,900 plus died. We're not done yet, unfortunately. Go back to this. How costly is that program? We like to think we just take care of patients. Cost is not supposed to mean something to us. If you need an endotracheal tube, you're going to get a new endotracheal tube. I was around when they used to wash some of that stuff. It worked, but I wouldn't go back there. They still did it. But the costly part is if you could sit there and analyze the data and say, hey, we had 30 patients last year who ended up in respiratory compromise after admission. They all ended up in the ICU. What was their hospital bill? Because if you know how much it costs the hospital, then you can figure out backwards and say, what can I do about it? Because if the cure isn't that expensive, we can do something. That's that cost effective. I got my anesthesiology colleagues. In a couple of months, I'm going to be luckily at Palm Beach at another meeting on the beach. Terrible. But one of the talks we were going to have last year was to remind my non-ICU colleagues is that you don't need the big tidal volumes in the OR anymore. And I know you guys see that because I see your blogs and your other stuff on Facebook sitting there going, they brought the patient out again and they set them up on a tidal volume of 12 milliliters per kilogram and not ideal body weight, just the whole thing. That's what I got taught. But I'm sitting there going, it's hard to break a habit because I'm looking at, I got the guy on 10 milliliters per kilogram of real weight and the peak inspiratory pressure is 18. Kind of hard to get excited about it. Till somebody does the data and looks at it and says that if you keep it below with a little more PEEP, and I get a lot of people, and there's still a lot of anesthesiologists don't use PEEP in the OR. They don't like it. And you're like, come on, you got to do some stuff. So they did everything else except the signs with that. Major postoperative complications in the patient. These are ones that are going to stay in the hospital afterwards anyway. So they were big surgeries. Over a fourth of the patients who got the larger tidal volumes had major complications. Only 10% who got the low tidal volume. You were discussing what do you do if you're in there and the doctor wants to do something you don't like. And you're like, I'm going to document it. all I could think of is one of the things when you go in and interview for a job, you have to, and when they ask, well, any questions? Yeah. Who do I go to when some doctor or somebody wants me to do something I think is dangerous? And I'm not worried that I'm wrong, but I want somebody to talk to make sure that what is done right for the patient. And so if you're walking around an ICU and they're putting on people on 10 to 12 milliliters per kilogram of tidal volume, if you're not saying something, you're going to be part of this problem. If they won't let you say something, unfortunately, if you're in a small town, it's the only hospital, you're kind of stuck. But otherwise, you ought to think about going someplace else because some other place will pay you to go to them. That's just not safe. We don't need to put up with that. The only other thing, and I can tell you, this is one company thing. I can't remember who does Prodigy, but they did at least one study, and this one looks at end-tidal CO2, and they did a double-blinded study. They just kept track of how a patient did. Now, yesterday morning in this room, there was a neonatal one talking about transcutaneous, how the end-tidal CO2 was too high and too low at different people. This is the same type of thing, looking at what happened to respiratory rate and end-tidal CO2. And it picked out the people who had narcotic-induced respiratory depression. Now, I can tell you, anesthesia is trying to do something about that by reducing the amount of narcotics. You got to help them. You got to, and that's the patient. When you look at some of the data, you say, hey, these are the people we need to monitor more. What type of patients? And so that's when he said we need other monitoring, more monitoring for a day or two. They've got to be someplace separate or not. That's what you do with the information when you get it. So I'm going to stop there because the other slide just talks a little bit more about that. I will be available. There's a break now. I'm available for questions in here. Otherwise, I'll be outside for a while. No problem whatsoever. You guys take care out there.